shall now go on to Dr. Harshul, who is going to be showing us another very challenging situation. On to you, Harshul.
Yeah, thank you so much, ma'am, for. So I'll be sharing a case of traumatic cataract. Can you see my screen, ma'am?
Yes. Yeah.
Okay. So this was the case, and this was a 28 years old male who came with this traumatic cataract, and along with that, he had a mydriasis here, traumatic mydriasis. So his pupil also needed some, something to be done here. You can see that the corneal tear repair, which was done, I think 6 or 7 years back. So the plan was to, of course, be ready with whatever zonal dialysis or whatever we encounter, if it's there, and do pupilloplasty also along with doing the cataract surgery. So make a limbal incision here. This is a clear corneal incision. It's a 1.8 millimeter incision. Stain the anterior capsule and start the capsulorhexis. So when you are doing capsulorhexis, you get to know that what is the status of the zonules. So here you can see that the rhexis is proceeding as it's needed. And so once the capsulorhexis is done, I just go ahead and trying to take this soft cataract, but I realize that it's not that soft. So I go ahead and chop this nucleus. I was very much careful that there may be a post-capsule rupture, because you never know, in traumatic cataract you may encounter a PCR along with the cataract. So all your maneuvers should be very meticulous and very gentle, and always try to maintain the anterior chamber so that even if there is a PCR, you don't extend that PCR. So luckily there was no PCR there, and this cataract was taken off to bimanual irrigation aspiration. And once that's done, I put a single piece foldable IOL in the capsular bag, and after putting IOL, I realized that rhexis was a little smaller. So I go ahead and give a snip here and enlarge the capsulorhexis to desired size. And after that, now the time comes to do pupilloplasty. So I stretch the pupil, this iris margin from both the sides here, so that put some myocol. Now I take a 90 Prolene suture. So for pupilloplasty, you go from this main incision here and hold the iris tissue with the iris forceps and give a stab incision from the limbus, so that you pass this needle through this iris, proximal iris here. And once you pass from this side, then you go ahead and I use a 30 gauge needle to railroad from this distal iris here, and you take this needle out. And after taking this needle out, you need to take this loop from the proximal iris here and take this loop out. So this is a single pass 4-through pupilloplasty, which has been taught by Dr. Amar Agrawal. It's a wonderful technique to do pupilloplasty in such cases. Then after that, you give 4 throws here. You just give 4 throws, you count them, and once you do 4 throws, you just pull both the ends and your job is done. So I just pull both the ends and tighten it. So after that, I realized that it needs one more here. So you go ahead and you can give one more knot here. And this. And after that, you again pull and your work is done. So you go ahead and hydro stitch all the incisions and your job is done. Thank you so much, ma'am.
Yes, as always, you are amazing with your videos, Harshul. So I'm going
Thank
to
you, ma'am.
ask you some questions here. Supposing the iris defect had been larger, what would your approach have been in that case? And when would you consider using partial iris segments also?
Yeah, I think that's the case when you need to use partial iris segment. If the defect is very large, in
Hmm.
that time you may need that.
Yeah,
So
you had a
pupilloplasty is not, yeah. So
yeah,
pupilloplasty is not possible.
He's pressurizing whatever it is, I will try. Okay. I convince him little bit.
I think,
So,
yeah.
yes, ma'am.
And did you do a hydro in your case?
Hydrodissection?
Yes.
No, I didn't
Yeah.
do.
So
Yeah,
that is another important message in a traumatic cataract. If you have not
yeah.
done an ASOCT and you have not confirmed about whether the capsule is intact, probably it makes sense to not do a hydro because you don't know about the status of the posterior capsule. And of course, it was a very small area of iridodialysis you had, Harshul, so it could be ignored. But supposing there was a large area of iridodialysis and also a mydriasis, uh, how would you combine both pupilloplasty and that? Because it is
So,
stretched in opposite directions.
yeah. So then you need to do iridolisis repair
Yes.
along with pupilloplasty. Yeah. So that's a wonderful technique shown by, that's a swing needle technique. I think that technique works very well. I use that technique wherever I need to do iridolisis repair.
Mhm.
And for pupilloplasty, SFT works wonders, I guess. So
Doctor,
once we have, yeah.
yeah. Dr. Rohit, do you have anything to ask? Dr. Ramurthy, anything to ask? Because it was such a beautiful self-explanatory video. I had to just hunt up some question to complete it.
I think Dr. Harshul is a rare talent.
Yeah,
He
So,
just shows that if you are good in one thing, you have to be good in everything.
yeah,
And that's
no,
that's
no,
the thing he has.
yeah.
That and Dr. Harshul, one question: What was there was corneal suturing also done in this patient? If I'm, as you said initially, because of the trauma.
yes. So this patient has history of trauma almost 6 years back. So when
Okay.
he came with this cataract, I was also surprised. I asked him, "Why didn't you go for cataract surgery for so long? Means this cataract must have been there for like 1 year, 2 year, maybe. But he said, "Yeah, we didn't go for surgery." So I was also not sure that what we're gonna achieve. But surprisingly, this patient had very good vision and everything went off very well.
I think the only thing, yes, if there is an associated astigmatism in high astigmatism, then pinhole
Yeah.
pupilloplasty could have been, you know,
Yes. Yes.
been added. But since it was off quite a bit of off center, and as you said, maybe the astigmatism was not profound. And what was the zonular status in the area in which
It
the
was good.
it was
You
good?
saw when I made X-rays, everything was perfect. There was no zonular instability. The capsular, yeah, it was perfect.
Yeah. So the one more
So
thing.
in traumatic cataract, we all know that we have to be prepared for everything.
Yeah.
So intraoperative, we may encounter anything. There may be zonular instability, weakness. We may need CTR, CTS. So we should be ready with everything.
Yeah.
But luckily, in this case, there was nothing like that.
Yeah. One and the additional thing which could have been tried is that that area where the iris was absent, the trypan view could have gone behind also. So the use of trypan view, if we can make it more judicious, the use of trypan view, that will not spill into the posterior segment and that will not impede the visualization. So
Yes,
one trick which at times we can do is we can instill some visco in that area, which
yes.
blocks it, and then you can add trypan view, not in a phased way. And I think it was perfectly done. Nothing more
Yes.
can be said.
Ramurthy, shall I go on to the next video?
Oh, superb demonstration, textbook demonstration, Astral. Congratulations.
Thank you,
I
sir.
just have a comment to make. I think it was already referred to. The sense I personally thought that the defect was fairly large. Sometimes in these situations, what happens is that you are able to approximate the pupillary margin, but peripheral to the area of approximation, there is a fairly large defect that's still visible. In these cases now, because we have got that, thanks to Amar, we are all becoming familiar with these procedures, and iris prosthesis is becoming available in India too. And in these situations, putting in iris prosthesis may be a good idea, because even though you are able to approximate the pupillary margin, sometimes peripheral to that there is a large area of defect. Because I remember this, ICL patient of mine, before the central flow came into being, inadvertently I had created a slightly larger pupillotomy. And that patient was, in spite of the fact that it was in the periphery, kept complaining about diplopia and the quality of vision being quite bad. It was quite a difficult situation to handle. So in these cases, maybe a prosthesis might be a better.
Yeah. So in this case, I didn't go for the third pass of SFT because there was a corneal scarring in that area, which I thought, which is already obscuring that part. You're right. Of course, if that area is large, you need to cover it with prosthesis. Yeah.
Absolutely.
Thank you. Actually, I just wanted to add one thing. After Dr. Kashyap, I would want Dr. Thomas's video also to run, because I have created the questions combined for both of them, because it is partly related to the posterior segment part of it also. So after that, we will go back to the regular sequence of cases. So on to you, Dr. Kashyap. We could go to you. Thanks a lot, Harshul, for your
No,
amazing
ma'am.
video.
No, ma'am. Thank you.